Hello students, welcome to EPG Pathshala. I am Dr. Renu Tyagi from Department of Anthropology, University of Delhi. Today I am going to discuss the module Morbidity Survey under the paper Research Methods and Fieldwork. The learning outcome of the modules are: number 1, to learn the definition and scope of morbidity; number 2, to understand the definition, types and application of the prevalence; number 3 is to know the definition, types and application of the incidence; and number 4 is to understand the relationship between prevalence and incidence. First of all, let us define the concept and scope of morbidity. Morbidity is defined as the extent of illness, injury or disability in a defined population according to the Timmer-Reck in 2002. Terms such as disease, illness, injury, disorder and sickness are grouped under the rubric term of morbidity. World Health Organization Expert Committee on the Health Statistics proposed the criteria for measuring the morbidity using the information such as presence of illness, period or spell of experience of the illness and duration of the illness. Morbidity data are useful to know the burden of disease in the community, to set the priorities in the public health management, to study the causation, to propose the effective intervention if the causes are avoidable, and to know the efficacy of the intervention as per the guidelines given by the Park in 2007 and Ostlin in 2010. Morbidity is measured by the disease frequency, duration of the disease and severity of the disease. Disease frequency is assessed by the prevalence and incidence, duration by disability rate and disease severity by case fatality rate. Now let us see what is prevalence. The prevalence may be defined as the total number of the existing cases, new and old, in a defined population at a given point of time according to Bonita et al. In 2006. Prevalence is equal to number of the people with the disease or condition at a specified rate divided by the number of people in the population at risk at the specified time. People at risk include the people who have the susceptibility to develop the disease under investigation, for example, susceptibility of the smokers to lung cancer. When the data on population at risk is not available, the population in the study area is considered as the denominator. Prevalence of the particular disease is studied using the representative sample. Appropriated sample size is calculated for the study. Subjects are recruited by employing the randomized sample technique, that is cluster, stratified, systematic or purposive. Prevalence can be reported by the age, sex, socioeconomic status, urban and rural background. For comparison of the data is age standardized using standard population of the country or the world. The prevalence is expressed per 100 or 1000. For the purpose of illustrating the prevalence study, a study conducted to assess the ischemic heart disease, that is IHD, a disease characterized by the reduced supply of blood to the heart in Siliguri, West Bengal, is discussed in this study. Ischemic heart disease was confirmed by the presence of history of angina or infarction or previously diagnosed disease. Affirmative response to the Rose questionnaire and Minnesota codes, that is electrocardiogram. Out of the 47 wards, 2 wards, namely 23 and 47, containing a total population of 14,568, criteria for the recruitment into the study were permanent residents in the chosen ward and aged more than 40 years. Assuming the expected prevalence of the IHD among the urban population in India was 9.6%. The accepted prevalence of 6%, confidence interval of 95%, non-response rate of 10%, the calculated sample size was 271. By using the updated voters list, a total of 271 subjects were enrolled in the study using the systematic random sampling technique. 257 subjects response rate is 92%. participated in this study. A total of 29 subjects were found to have the IHD corresponding to 11.6% with a prevalence of 29 by 250 into 100 is equal to 11.6%. Several factors like the longer duration of disease, prolongation of the life of an uncured disease, patient increase in the incidence, in-migration of the cases and susceptible people, out-migration of the health people, and improved diagnostic facilities were shown to increase the prevalence and vice versa decrease the prevalence as per the Bonita et al. Study in 2006. Now let us understand the type of prevalence. Prevalence is of three types: a point prevalence, period prevalence and lifetime prevalence. The point prevalence, the prevalence data collected at one point of time is referred to as the point prevalence. Data on the point prevalence is useful to check whether any outbreak has occurred in the community. For example, study conducted on usage of the antimicrobial agents employing the European Surveillance of Antimicrobial Consumption Point Prevalence Survey Audit Tool on 3 separate days in the study period of the 2 weeks in National Center for Cancer Care and Research, Qatar. It was found that the usage of the antimicrobials was 43% with penicillin or beta-actamase inhibitor combinations predominantly 39%. Figure 1 shows the formula for the point prevalence. Now next is period prevalence. Period prevalence is calculated by using the numerator, total number of cases at any time during a specific period, and denominator, population at the risk midway through the period. For example, the study of the chronic obstructive pulmonary disease, that is COPD patients in UK, a type of constructive lung disease characterized by the chronically poor airflow, patients admitted to the General Infirmary, St. James University and Killingsbeck Hospital, Leeds, were studied for 1 year period. 11 patients required incubation placing of a flexible plastic tube into the trachea, windpipe to facilitate the airway and to serve as a conduit to deliver the drugs. 20% of the patients had respiratory acidosis, an excessive acid condition of the body fluids. Acidosis was associated with the subsequent admission to the intensive care unit. In almost half of the patient with hypercapnia or abnormally elevated CO2 level in the blood. 80% of the patient remained acidotic after initial treatment. The calculated prevalence of the acidosis was for men 75, that is 95% CI with 61 to 90 per 1 lakh per year, and for women it was 57 with 95 CI as 46 to 69 per 1 lakh per year respectively. This study also suggested the requirement of the non-invasive ventilation for 80% of the patients with complaints of acidosis. Now let us see what is lifetime prevalence. The total number of the persons known to have had the disease for at least some part of their lives is known as the lifetime prevalence. Examples of the lifetime prevalence study of the psychiatric disorder in South Africa. The data generated in this type of studies are useful for planning a mental health services. This study was conducted between January 2002 to June 2004. A 3-stage probability study design was used in this study. In the first stage, sampling area were selected. In the second stage, housing unit within the sampling area was selected, and in the final or third stage, the adult respondents were randomly chosen. If the selected subjects refused to complete the interview, another subject was selected from within the sampling area. For the diagnosis of the disorders, World Health Organization's Composite International Diagnostic Interview version 3 was used. This tool generates diagnosis according to the criteria of the ICD-10 International Classification of the Disease and DSM-4 Diagnostic and Statistical Manual of the Mental Disorders diagnostic system. A total of 5,089 households were selected and the authors could interview 4,433 households with a response rate of 87%. In the final analysis, data from 4,351 households were used. The lifetime prevalence of the various disorders in the following proportions were found. Anxiety disorder was found to be 15.8%, mood disorders were found to be 9.8%, substance use disorders were found to be 13.4%, and any other disorder as 30.3%. Difference in the life prevalence of the substance use was observed between racial groups. The early median age onset of substance use disorder, then anxiety or mood disorder, was reported by Stein et al. In 2008. Now, let us see the application of prevalence. The prevalence studies are useful in assessing the burden of the disease, initiating the preventive strategies, planning healthcare infrastructure, identifying high-risk people, and finding association between various variables and disease. Limitation of the prevalence studies is that they are not useful for finding etiology of the disease. Incidence is the rate at which the new cases occur in a population. So, incidence is equal to the number of new events in a specified period into 10n divided by number of persons exposed to risk during this period. The incidence is expressed per unit of time. 10n can be the days, week or month or year. The observation period for the individual in the population is as long as he or she remains disease free. The denominator is calculated by summing all the disease free person time period during the observation of the population at risk. If the population is large, stable and show the low incidence, the denominator is calculated by multiplying the average size of the study population by the length of the study period. Each person in the study add 1 person per year to the denominator for each year or day, week or month of the observation before the disease develop or a person is lost to follow up. One of the example of the incidence of the obesity in children of United States. A cohort of 7,738 participants who were in the kindergarten were studied from the period of 1998 to 2007. Their heights and weights were recorded 7 times during the study period. At the time of the recruitment, 12.4% were obese and 14.9% had overweight. The prevalence of the obesity and overweight increased at subsequent year and reached 20.8% obesity and 17% overweight in the 8th grade. The annual incidence of the obesity decreased from 5.4% during kindergarten to 1.7% between 5th and the 8th grade. It was hypothesized that incident obesity between the age of 5 and 14 years was more likely to have occurred at younger ages, primarily among children who had entered kindergarten overweight, as per the study reported by Cunningham et al. In 2014. Now, let us see the type of incidence. There are 2 types of incidence, that is cumulative incidence and incidence rate. The cumulative incidence measure the occurrence of the new disease. The denominator is measured at the starting time of a study. It shows the probability of individual in the population developing the disease during the specific period. The synonymous terms used for this indicator in the literature are attack rate, case fatality rate or lethality risk and incidence proportion. Now, let us see what is cumulative incidence. Cumulative incidence can be calculated as the number of people who get a disease during a specified period as numerator to the number of people who get a disease during a specified period as denominator. The period of observation can range from years to the lifetime. It is often presented as cases per 1000 population according to a study by Bonita et al. In 2006. For example, food hypersensitivity study in the children of the Isles of Wight, UK, birth cohort consisting of 969 children were assessed in their first 3 years of life on the prevalence and cumulative food hypersensitivity. These children were asked to undergo skin prick testing, pricking the skin with a needle for pin containing a small amount of the allergen, to food like milk, egg, wheat, peanut, sesame and fish. Aeroallergens like house dust, mite, dermatophagoids, pteronicinis, cat and grass and other allergens if identified by history. The prevalence of the sanitization of food for the first, second and third year was 2.2%, 3.8% and 4.5% respectively. The cumulative prevalence was 5%. The cumulative incidence of 6%, that is 58 out of 969, food hypersensitivity was observed among the study participants. A cumulative incidence of 5%, that is 48 out of 969, FHS was observed when the study participants were subjected to double-blinded, placebo-controlled food challenge. Now, let us see the incidence rate in view of the difficulty in establishing the fixed cohort to follow the over time dynamic population in which individuals enter the study at different time periods and leave or lost in following up due to the death or refuse to remain in the study for other reasons are used. The incidence rate, that is IR, is used to take care of these variations in the follow-up of the study. The incidence rate may be defined as the frequency of the new cases, occurrence of an event in a population at risk of the disease in a period of time. The calculation of this indicator requires details like the frequency of the new cases, the population at risk and the time period. The range of the incidence rate can be from 0 to infinite depending on the unit of time used to present the person's time incidence. The IR can be used to construct the relative risk and also may apply either when enrollment is at about the same time or spread over time. The IR neither useful as a measure of the absolute risk nor can predict the population estimate. IR is also known as the force of mortality, force of morbidity, incidence density, hazard and hazard rate. The incidence rate can be calculated as the number of new cases of the disease arising in a defined population over a given period of time to the total person time at risk during that period. The sum of the time that each person remained under observation and was at the risk of becoming a case is referred as the person time at risk. The time is expressed as the person day, person month or person years. For example, nephritis patients follow-up study in Sweden. Patients with the lupus nephritis of the kidney caused by the systematic lupus erythematosus disease and anti-neutrophil cytoplasmic antibody associated nephritis ANN, necrotized and crescentric glomerulonephritis from Skåne Hospital in Lund and University Hospital in Linköping, Sweden were followed for 12 years to study the survival and complications in them. In this study, 28 patients with AAN and 27 with the LN were diagnosed. The annual incidence of the AAN and LN for the aged more than 18 years per million were estimated to be 13.2 and 4.3 respectively. 36 patients with AAN and 2 patients with the LN were died in the follow-up of the study. 19 patients with AAN and 1 patient with LN had developed the end-stage renal disease. Now, let us understand it with the help of an example. 150 men with impaired glucose tolerance were followed for the time period of 4 years. After 1 year, none was diagnosed with diabetes, but 50 subjects left the study in the second year. 1 developed the disease out of 50 subjects. lost in the follow-up in the third year. 4 were diagnosed with the disease. 390 subjects left the study in the fourth year. The 6 had the disease, but 196 subjects left the study. It is assumed that the subjects with new diagnosis of diabetes and those left the study were considered disease-free for half the year and contributed half year to the denominator. Numerator is equal to number of new cases of the diabetes is equal to 0 plus 1 plus 4 plus 6 is equal to 11. The denominator here is equal to persons year of the observation is equal to 1 into 1.5 plus 4 into 2.5 plus 6 into 3.5 plus 50 into 0.5 plus 50 into 1.5 plus 390 into 2.5 plus 196 into 3.5, which comes out to be 1793.5 or rounded off to the 1793. The incidence rate of 11 by 1793 is equal to 0.0061 cases per person year or 0.6134 cases per 100 person year or 6.1 cases per 1000 person years. Now let's understand the application of incidence. Incidence is useful to know the occurrence of the new disease and outbreak of the epidemics, to assess the risk of becoming, to study the acute disease and etiology in chronic diseases, and to monitor the prevalence effect. Incidence is not influenced by the duration of the disease according to Parks 2007, Osland et al. 2010 and Bonita et al. 2006. Table 1 depicts the difference between prevalence and the incidence. Now let's see the relationship between prevalence and the incidence. The relation between the prevalence and incidence is explained by the bath model. The inflow of the water is compared as the incidence and existing water in the bath is given analogy to the prevalence according to Park in 2007. Prevalence is compared with the photograph and an incidence to a movie. Prevalence is decreased due to the death or recovery from the disease, migration of the ill people and acute nature of the disease. In case of the cancer, prevalence is lower when the incidence and duration of the disease are stable. In a fixed population, prevalence is equal to incidence into average duration of the disease. It is not possible to predict the prevalence from the incidence in dynamic population due to migration into and out of the population. Deaths, changing disease rates, change prognosis and error in measuring the incidence or prevalence. Incidence is useful in studies dealing with the causation of the disease and assessing the burden in short duration, whereas prevalence studies may be applicable for the studies assessing the burden in disease of long duration. Behavioral variable and disease related risk factors. In the absence of the incidence rate, prevalence rate can be used provided the duration is taken into consideration. Figure 2 shows the relationship between prevalence and incidence, whereas figure 3 displays the relationship between prevalence and incidence, that is Bath model. Now let's summarize the module. In this module, we have understood the concept of morbidity, we have understood the types and application of the prevalence, we have understood the basic difference between the incidence and the prevalence, and the relationship between the prevalence and the incidence. By now we know that morbidity is the extent of illness, injury or disability in a defined population. We have understood that prevalence is nothing but the incidence multiplied with the average duration of the disease. It is not possible to predict the prevalence from the incidence in dynamic population because of different factors like migration or the morbidity or mortality factors. Thank you.